Assalamu alaikum. Bismillahirrahmanirrahim. Today's topic is resistant hypertension and role of renal denervation therapy. Resistant hypertension can be defined as the blood pressure that remains above the goal despite the recommended treatment strategy, which should include lifestyle measures, maximum tolerated doses of 3 different drugs. There should include a diuretic, an ACE or ARB, and a calcium channel blocker in patient adherent to the treatment. And the inadequate BP control shall be confirmed by ambulatory BP monitoring or home BP monitoring, and after exclusion of various causes of pseudo-resistant hypertension and secondary hypertension. It is quite prevalent. Up to 12 to 18% of the hypertensive patients have resistant hypertension. And who is at risk? Mostly elderly, female, obese, diabetic, chronic kidney disease. They are vulnerable to resistant hypertension. The causes of pseudo-resistant hypertension must be excluded before labeling a patient with resistant hypertension, which include inaccurate BP measurement techniques, white coat phenomena, poor adherence to antihypertensives or suboptimal doses, and poor adherence to lifestyle and dietary approaches. We should also keep in mind drugs that raise blood pressure, which include oral contraceptives, steroids, NSAIDs, sympathomimetics, cyclosporines. And before labeling resistant hypertension, we should also exclude secondary causes of hypertension which are identifiable and treatable, including primary aldosteronism, chronic kidney disease, obstructive sleep apnea, renal artery stenosis, etc. How do we manage these patients? Lifestyle measures are important, especially sodium restriction, identifying and treating secondary causes, stopping any medication that raise blood pressure, and improving adherence to antihypertensive therapy. Pharmacological therapy is more elaborate in this slide. Stepwise approach to pharmacology. First, optimize 3-drug regime, including RAS blocker, calcium channel blocker, diuretic at maximum tolerated doses. If BP is not at target, substitute the prior diuretic with thiazide-like diuretic. And then in another step, add mineralocorticoid receptor inhibitors. And then beta blockers, alpha beta blockers. In the 5th step, we can add hydralazine plus minus isosorbate mononatrate. And lastly, alpha blockers. And if BP is still not controlled, then we can refer to a hypertensive specialist or for ongoing interventions. Now coming to the main topic, why do we need devices and renal denervation to treat hypertension? We all know that drugs, therapies, and lifestyle measures do work. They decrease blood pressure, morbidity, and mortality, but treatment is lifelong, cumbersome, and at times expensive. Patient can become non-compliant. So the device-based therapies and renal denervations are attractive options. They were invented possibly to cure hypertension, limit or eliminate drugs, help improve hypertension control, and were thought to be one-time procedure. This is the basic physiology demonstrating that there is an active relation between brain and kidneys via sympathetic nervous system, which increase blood pressure, via renin release, via increased sodium retention. And if we inhibit and modulate this sympathetic nerve activity, we can decrease blood pressure. Currently, we have 3 approaches to modulate and this for renal denervation. The first and time-tested approach is the radiofrequency based catheter used for last 10 years. Then the newer method for last 1 or 2 years, ultrasound based renal denervation, in which a balloon is placed in the renal artery and it emits ultrasound in a circumferential fashion, while the last and newer method is alcohol mediated or chemical mediated renal denervation, in which there is a catheter with microneedles at the tip which infuses ethanol in the renal arterial walls. Now if we have these devices, the question is, do these devices work? What is the evidence? So these adventures have been started in before 2010. This is the timeline of renal denervation landmark trials. Everything above the blue arrow are the trials which randomized sham-controlled arms, while the trials below the blue arrow are randomized controlled trials without a sham group. And the trials in the red print did not achieve their primary endpoint, while the green printed trials achieved their primary goal sets. First, I will discuss the spiral, simplicity spiral catheter, which is the multi-electrode catheter devised and manufactured by the Medtronic, and it delivers energy for 60 seconds, and the catheter used can be 6F guiding catheter as we use for angioplasty. On the right side of the screen, you can see how does they appear angiographically. We can see that in a perpendicular view, the electrodes in the catheter are at 90 degrees with each other, and in the lower angiogram, we can see that this catheter can be used both in the main renal artery as well as in the renal branches. So, this Medtronic has started these clinical trials for more than 10 years, and so far, more than 4,000 patients have been tested, and this is called Spiral Hypertension Clinical Program. And few of these trials have now decent long-term data. These are the results of this Spiral Hypertension Clinical Program summarized on in this one slide. The upper panel shows the 24-hour BP results, while the lower panel shows the office systolic blood pressures. And the dark blue bars show the patient who underwent renal denervation and the depth of BP drop with this procedure. On the left side, the two pathways are off-med pathways, while on the right side, the two pathways were on-med pathways, patients who underwent renal denervation and who were taking antihypertensive treatment. In all these pathways, we can see that there was significant BP reduction. And again, the same message, 24-hour blood pressure after renal denervation at 3 years, we can see that there is significant and persistent BP reduction after 3 years. And the same information in another way, the off-med pathways are on the left, the on-med pathways are on the middle, and the right and the left two pathways are the European registries, and all shows significant BP reduction. And as it is an invasive procedure, so safety must be considered, and we can see that these procedures have excellent safety profile. Out of 253 patients, only one patient has a vascular problem. The next is the ultrasound-based renal denervation system, in which a balloon is passed to the renal artery over a wire, and the balloon emits ultrasound energy in a circumferential fashion up to 3 to 6 millimeter in the renal arterial walls. And each sonication is given for 7 seconds, and in each artery 2 to 3 sonications are done. How they appear angiographically? First, we do a renal angiogram to outline the renal arteries, then the balloon is passed into the renal artery, and then the energy is delivered. Recor is the company which has launched this balloon-based system, and the main trial is Radiance Hypertensive trial, which has different arms. They also have on-med trial, med arms, off-med arms, and Radiance 2 trials. I will not go into the detail, but the results of these trials also showed there is a significant BP reduction. And all these trials pooled in this one diagram shows that about 8.5 millimeter reduction was noted as compared to the control group. And again, 24-hour BP reduction, persistent 24-hour BP reduction with these procedures. And again, there was very minimum number of patients has some vascular events, or its safety was excellent. All these trials which I have mentioned are summarized on this page, whether balloon-based, ultrasound-based, or radiofrequency-based. They showed that ambulatory BP monitoring reduction was at 8.5 millimeter, of mercury, and office BP reduction was 11 millimeter mercury. Changes are small but clinically relevant. And in the last, the catheter-based infusion of ethanol into the renal arteries. The catheter has small micronodules and alcohol is infused into the renal arteries. And the trial being performed on this strategy was Target BP1 trial. It has completed, but the results are not yet established or disclosed. So, in conclusion, renal denervation therapy is validated by prospectively powered sham-controlled randomized controlled trials. Statistically significant and clinically relevant BP reduction were noted, both in the absence and presence of antihypertensive medications. There were no major procedure-related safety events across multiple trials of different devices. BP reduction via renal denervation therapy persists across 24 hours and is not subject to non-adherence or pharmacokinetic actions. Renal denervation can serve as an adjunct therapy of hypertension for patients with resistant hypertension. Now, after listening all these trials, what does FDA says? Has FDA approved this method for controlling hypertension, and what does the guideline says? So these two companies, the Recor company and the Medtronic, have submitted their data and these trial results in the FDA, and they will decide in August this year, and hopefully they will approve this device for specific indications. And the Society of Coronary Angiography and Intervention of United States, they also have adopted guidelines, and the European Association of PCI have also devised consensus statement. In the summary of all these documents, we can make some clinical considerations. This is the last slide, that current and future management of hypertension should include optimal medical therapy plus renal denervation therapy for most of the patients. Renal denervation alone can be used in rare patients who cannot tolerate any medications. Patients should be well informed about the risks and benefits of the procedure, and the decision making should include well informed hypertension experts. Thank you very much.